All right, another episode of the Square and Compass podcast with Doctor and Right Worshipful Brother Oscar Allen. He is with the National Association of County and City Health Officials.
I am the Chief Program Officer of the National Association of County and City Health Officials.
That's right. And I know so when we talked about your position, you mentioned you're supervising over 100 staff, um,
Yeah.
all of whom are working incredibly hard right now, liaising with local health officials, especially right now, in the middle of a pandemic. I can only imagine the work that you're doing and that your staff is doing.
Yeah, since day one, we've been engaged. The National Association of County City Health Officials is the national organization here in the U.S. that is the only one that represents the 3,000 local county and city health departments across the country. And that varies whether it's a county with the size of 7 individuals to big cities that have over 500 staff members. So when you think about the several programs and services that are engaged at that level, essentially whether it is disease reporting, provision of vaccination, women, infants, children's programs, diabetes, case management, heart disease prevention, cancer, and all these other elements. These are what we call the essential public health services that are conducted, much as similar you would have like a, Public Health Canada or all health, the public health services in England, essentially, or the Ministry of Health. That the 3,000 health departments essentially are corralled with respect to the National Association in both being a voice for them at the national level, both in the interaction with the federal agencies of health, CDC, NIH, FDA, whatever alphabet soup, that's their engagement point. In addition to really focusing on the policies and ensuring, especially in Washington D.C., that the legislation and the Congress really have a better understanding as to the value of public health and really ensure that their programs, their services, and their existence are protected. Because oftentimes people only remember health departments if something goes wrong, or let's say they're like, "Well, I need someone to inspect a restaurant because I think I got food poisoning." Not thinking about the other hundreds of programs and services. And as I mentioned, since January, when we got first wind, late December, we got first wind in January, put into the state of readiness. I've been the incident commander for the national response for the organization. So I've been embedded with the CDC, with the FEMA folks, with the Assistant Secretary for Preparedness and Response, interacting with White House and a few other elements in trying to ensure that the plight and the concerns of local health departments are heard and understood during this COVID pandemic.
I like how during your description you talked about all the different services and work that is provided. Um, how one thing that we see so much of nowadays in the news is the focus on COVID-19. How much are not just yourself but are local health communities and organizations struggling to try to balance the current crisis with all those things that don't go away? Whether it be um, uh, we hear about places canceling elective surgeries and hospitals having to balance, the needs of cancer patients and that type of thing with obviously the current crisis. So how much of a burden and a struggle has that been?
So to quantify it, it has been an intense struggle and burden for several reasons. When the pandemic first hit in the spring, the reality was that, especially when it went into the goal of trying to put stay-at-home orders in place, several things suffered. We saw automatically that there was a significant reduction in childhood immunizations because children weren't able to go to the doctor's offices. Parents weren't able to take them; they had to stay at home to that extent. So automatically, while we were concerned about the COVID crisis in that regard, we also recognized that there are other things that were unintended consequences. The ability for folks to really address, proper food and nutrition. Oftentimes in this country, there's certain segments of the population where their food or their means of nutrition is tied to their educational exposure. So they go to school to get proper meals because of whatever situation they have at home. So now you're not in school, now you're in a home environment. How are you ensuring that the nutritional value is really being provided to those at-risk populations? Similarly, when it comes to addressing prevention, like health and welfare, the food insecurity issues, all of these things essentially get very strained. On top of that, several of the staff members were pulled off of the work that they normally do to address COVID. So there was a significant shift in the staffing capacity and their ability to fill in, as we would say, to cover for things that aren't being done. And when you started to see the run on focusing on getting contact tracing and case investigation, that really added much more folks that needed to be hired, needed to be addressed, while at the same time shifting those resources. And one of the other unique aspects of this, which has really been one of our biggest problems through this entire pandemic, is that we saw a shift in the culture and in the societal understanding of public health, especially with respect to the attacks against science. So oftentimes we would say the health authorities are oftentimes the unsung heroes. No one knows them. They're there working on stuff. I mean, I can tell you hundreds of outbreaks that I've helped either track, trace, or address, and no one would be none the wiser. But with respect to at least in the U.S. Side of the coin, with respect to the anti-science stance and some of the politicization that we saw, oftentimes many of our members, many of these same folks who are stressed, they're trying to address the community needs, they're trying to get PPE, they've shifted their roles to focus on COVID, then they got targeted. We've had people whose lives were threatened with death threats, who's been physically, harmed, who's been, attacked on social media, people showed up inside their homes. We've had over close to 100 local health department officials who've simply been fired, retired, or got pushed out because of concerns about their following the science in that regard. So that burden on top of the exasperation of doing the response, you can understand why I quantified it as saying, or qualified it as saying, an intense burden and stress.
That is something that is so. I mean, for me, it's a combination of fascinating and frightening at the same time. If I was in your shoes or in, a healthcare worker's shoes, it'd probably be only frightening. But being that
Mhm.
I can look at it from a bit of a distance, this um, polarization, or just like you say, these strange distrust and attacks on what seems like relatively common sense approaches to be taking. Um, yeah, it's just been a really fascinating and at the same time frightening kind of turn of events. Um, was there, pre COVID, pre January? I'm sure that there were people thinking about these type of things happening and pandemics. Was there, did anybody suspect that you might see this, the public and kind of the way the public is reacting in some cases to
No,
these measures?
no. We, how do I say this? For 20 years of my professional life in public health, I've been engaged in both disease outbreaks and emergency response planning. I helped in my county in response to 9/11. I was, part of the anthrax response group, the smallpox response team. We helped draft and do tests of both several of the emergency response plans. I served for several years as the on the disaster medical assistance team, which is a federated group of when something happens, you get rolled out to go out and try to help with the medical and the public health response. In none of those scenarios, in none of the tests or the drills that we do, or the exercises, or the actual experiences that we had we ever faced a public pushback on the work that we were doing. And anything when you have a outward facing public servant, delivery of services, you're always going to get complaints. Someone felt that they weren't, prioritized, etc. But we've never had the breadth and the intensity of backlash against public health and public health decisions as we've had. None of us were ever prepared to experience what we have been and continue to experience, because we've always viewed public health as an altruistic approach, that everyone's looking for the common good and the betterment of your community, so that when something does happen, and in our drills and exercises and our experiences, we say, this is what we need you to do, people tend to, yes, they ask questions, we explain, but they don't tend to say, we don't believe you, we're not going to do what you say, to hell with you, and actually we want to take you out because you're a harm to us. So that's something that I would say caught us all off guard. We've had years of planning. Most of our plans were never utilized because of, once again, some of the decisions that were made that shifted the roles and the responsibilities from what we normally will engage in, from a disaster response side of a coin. But nonetheless, this public approach, and especially around the role of the simple mitigation factors, like staying at home, physical distancing, wearing a mask, and trying to curtail travel until we can get a handle on stuff. There are simple things that we would think would be advisable and folks would rally behind, but just even the politicization around mask wearing here in the U.S., something which is so simple, but at the same token, became such a divisive, conversation piece. None of us were ever prepared for that. Yeah, and especially when it comes to the vaccine, and even before the vaccine, the just disinformation about the virus and the pandemic. You still have people saying it's a hoax, which just boggles my mind. But on the topic of vaccines, even when we testified as a national organization and provide our messaging to the folks who were creating the prioritization list for the communities for the vaccines, even in my professional context, when I presented that and at ethics and bioethics conversations, I mentioned the fact that we do recognize that there's a history of mistrust and distrust in key populations in the U.S. and in other parts of the world, but specifically as it pertains to the U.S. and the African American community. It doesn't just start with Tuskegee. In slavery, of course, the impacts there, but we even know that the father of modern gynecology, a doctor by the name of Dr. Sims, he performed all of his techniques in gynecology and experiments and observations on enslaved African women, and all of those were done without any sort of anesthesia, because they were of the mindset that Black people had no feelings. They weren't human. So you can do this. And they were very horrific. In some cases, we kind of liken it to basically medical apartheidism, in the sense of how, Black people were treated for the benefit of science. And then that science goes on to the benefit of, the populations that were in the majority. So that was one. Then we see the story of Henrietta Leaks, right? She was a Black woman who, in the early 1920s, she had cancer. They didn't necessarily treat her, but they took her cells, and that went on to be the cells that, for generations to this day, still exist. And they never told her that they're taking her genetic material, or that they were performing tests on it, but that it has led to probably more scientific breakthroughs, but with no acknowledgement until later on, for both her and her family, if she had passed on, of course, that people had taken her genetic material without her consent and used it for scientific purposes. So when you think about that, and then of course you get a Tuskegee, and one of the concerns that I've always had when people bring up Tuskegee is Tuskegee was not the same scenario as we see now. Tuskegee, they two gentlemen under the U.S. Public Health Services, attempted to follow what how syphilis impacts the black population or in people in general, but predominantly in black men without treating them. Now, they pretended that they were treating them, and that the treatment at the time wasn't necessarily as great. But while in the course of that study, a good treatment did come in place, and they still refused to treat those men. So they lied to them about treating them. They followed their disease progression. Several died, of course, and syphilis has a very negative outcome on overall health and safety. So that in of itself was a significant crime, and one that I believe the U.S. Public Health Services continues to recognize that it must atone for. The difference between that and this vaccine, or even with respect to COVID, no one's looking to see how COVID is going to progress in the African American community. We see what it's doing to all populations, and specifically how African Americans, Native Americans, Latinx communities, and predominantly people of color, they are disproportionately being impacted by this pandemic than anyone else. Now we have a vaccine. I'm
Oh,
sorry.
where does
That's,
that disproportionate effect come from? Is it you hear this term a lot, like comorbidities, which I'm not very smart, so I'm not completely sure what that means.
sure.
But you hear
So,
terms like that, or is it socioeconomic, or what's the correlation there?
so it's all of the above, but predominantly the social, what we call SDOH, social determinants of health, and I'll explain that in a minute. But with respect to comorbidities, that just means that you have multiple diseases at the same time. So you can have diabetes and you can have cancer. You can have asthma. You can have heart disease. So when you have these multiple illnesses, to some extent, they further weaken your ability to live a health and safety life, so live a healthy and safe life. So in those scenarios, let's say you're sick from one thing, and you have other things that actually adds to the ease of you becoming more sick. Right, so that's you're comorbid. So not only do you have an issue with a respiratory disease, you have obesity. So therefore, your obesity, which is going to add to your inability to rebound faster, is maybe going to add more to you becoming sicker. So with respect to, let's say, having COVID. Now, the other piece to that pie is that of the social terms of health, which you asked about. Specifically, social determinants of health just basically says that there are significant factors outside of genetic, outside of hereditary, and outside of individual choices that have an impact on your health. And oftentimes they can be, family, community, as well as upstream, what we call policies and other things that are truly built in that have an impact on how you have a health and safe well-being. Perfect example: you may be 18 years old, just using that example, and you live in a community where there's high traffic. There isn't a footpath, no sidewalks, but there's high traffic, high volume traffic of cars, trucks, etc. So that automatically means that you're going to have a different air quality than someone who lives, let's say, in the suburbs, where there's not a lot of high volume of cars going by. Let's say you're in that same community and your food access is very poor, meaning you only have high processed foods and not natural, organic, or readily available foods. So you may have more, pardon the expression, more fast food outlets, McDonald's, Jack in the Box, whatever they call it, versus that of, home cooked prepared meals that are more nutritious. So you add that, you add the environment in which you live, you add maybe even the quality of your housing, the inability to make as much money or equal amount of salary because of either education or lack of access to education. So when you compound all of these things, and then you add on that several of the individuals who are in these kind of categories, let's say you look at the essential services folks, those are the folks who drive buses, who are clean, who provide those the garbage collection, all those other elements, and they tend to, in the service industry, and they tend to be people of color. So they're lower paying jobs. You're in a population that already has a high risk of getting sick. You are in low low wage earning capacity, you may not have access to enough sick leave. You may not have adequate access to health care. So your health care is all, so you get sick, you can't go see a doctor in relative terms. And then on top of that, let's say you also don't necessarily have the ability to see a doctor in the area where you live in a rapid enough time, et cetera. So all of these things compounded, all of these things put together really are factors that truly have an impact on your health. In fact, we say you can probably tell someone's life expectancy by the zip code in which they live. So it doesn't matter whether or not you're healthy and safety and you work out every day, or you make it. Based on where you live, we can sometimes tell you, are you going to die at this age or are you going to die at that age? So put that all into perspective, right? You have all of those mitigating factors in play. Then you have a respiratory disease that attacks in the way that it does attack, that takes advantage of if you have comorbidities as well as your other social demographic factors. Let's say you live in densely populated areas on top of each other. You have a multi-generational family, so it's not just you and your mom and dad. It's you, your mom, dad, your cousins, your whomever it may be. All of that adds to the capacity for this respiratory disease that we've never had before to really grow, to proliferate, and take people out in the way that it has. So those are the subsequent reasons that we recognize that it's both the individual, health and their defense mechanism to fight off a disease like this, a new disease, and then all of the other pile on factors that truly shows that you're more at risk than anyone else when it comes to this particular disease.
How much, the one thing about social media that can kind of make things a challenge, I think, is even from people who are, well-intentioned or good actors, good faith actors, is we tend to, it feels like we have a lot of conversations at the same time, as opposed to being able to triage in terms of what their priority is. So as you discussed, with comorbidities, it seems like a lot of people on social media, whenever people bring up the COVID death stats, will cite underlying health conditions, or they'll say a lot of those people had diabetes or X or Y. And it seems to me that that's a relevant point for later, in the sense that, we do want people to be taking as much as possible care of their health so they don't develop type 2 diabetes that makes them more susceptible to any type of disease, flu, COVID, whatever it is. But that doesn't mean that at this present time, that should be our focus, is on comorbidities necessarily. It seems like everybody's trying to have their own conversation at once, as opposed to relying on the health officials who have been, trained in this, to focus on what's important right now versus what's a policy for down the road. Even, the social determinants of health. As you talked about at the start, a lockdown will have an effect on those social determinants in terms of
Mm-hmm.
employment and income. But
Mm-hmm.
is it a matter of, there's things to worry about in the future and things to look at right now, and right now the goal is get this under control? Or is it possible to have
Well,
every conversation that, to prioritize those conversations?
yeah, I would say, to be honest, we've been talking about social determinants of health and the impacts of race and ethnicity on health for years. And people weren't really listening. Some people paid attention, of course, but to the extent where you try as health experts to discuss and illustrate how these things do have an impact on health and well-being, unless most folks would say, unless I'm from that community, why do I care? Once we begin to see this pandemic knocking down the populations in a disproportionate numbers, the way it has, where the hospitalizations and the death rates are much higher. Now, don't get me wrong, the false sense that sometimes people have is that, well, this just means that black people are dying and Native American people are dying and white people aren't. No, we can show you by the raw numbers, everybody is getting sick and dying from this. What we're seeing is a disproportionate number based on the population dynamics. So whereas, let's say you're supposed to be, African Americans are supposed to be 15% of the population, but they account for like 39 to 49% of the deaths. That's disproportionate. So just by that factor alone, you're going to see a greater risk to those populations, and why it's important to discuss them and why they're seeing that. So, to the extent of recognizing that we have an issue at hand and we need to identify what are the solutions to that, there is the initial, or as we would say, the acute phase of let's just make sure people who get into the hospital can get the necessary treatment so that they don't die within 3 to 4 days, or upon being intubated, that that they don't come out of respiration. So there's the acute phase of getting the treatment, getting folks access to the proper care, right? So that's important. But seeing that we're in a pandemic, which is now going into completion of year one, it tells us that we're in this for a longer marathon than a sprint. So therefore, it's going to be important to recognize how to address not only the acute phase of just a disease, but the long-term impacts, because we also recognize that COVID, it's not as simple like I got COVID and I got better and I've recovered. There are some implications and additional health implications that we recognize are going to be a lot more long lasting than we would have liked. So it is going to be important to both factor in how to address those particular concerns, what are all those factors that can play a role, and how we can how we can improve them, while in the same token maintaining vigilance and really strengthening the health systems that we have in place, so that if we're truly thinking about things from what we call a disaster response model, you look at the preparedness side, you look at the response, resiliency, and the recovery phase. So it's an entire swath of interactions. That's not just one over the other, but as a process by which we hopefully can learn, respond, adequately identify, and focus on what we need to rebound and continue our efforts, past this particular activity.
So one of those efforts, the one that has definitely got a lot of press, and I think is giving a lot of people hope, but as we talked about, some people a certain level of fear, is vaccines. And I came across the way I got in touch with you was through our friend, worship brother Edgar Barron, who had a presentation at his international Masonic town halls, or you gave a presentation at those town halls on the vaccines. Um, I'm I've certainly felt a sense of hope when I first learned that they were being rolled out and saw the news stories of the first ones being administered in Canada. But having said that, I'm the first to admit I don't know anything about vaccines or how they work. Um, and a lot of people, and I guess it's reasonable, have expressed concerns over, even Masons I know, expressed concerns over, they feel like it was a short time period from when we first had COVID. They feel like the process was rushed. So I guess my question is, uh, with your medical expertise, was the process rushed? How did the vaccine work? Are there potential dangers? Kind of just your take on the vaccine process.
Sure. So a couple of things normally happen when you go through a vaccine development, a vaccine trial. You go to a phase one where you're trying to focus on where things are, what's working, what is your idea for the vaccine development? How has it responded to a small subset of people? If it becomes promising and shows some favorable results, then you go to phase two, and in phase two, you widen the scopes because you want a much more diverse population to see what are the implications. So you're not just biasing to one group of people. Phase three is similarly, you go into a larger full trial, much more individuals in the tens of thousands, if not more. And the goal there is to once again look at what we call safety and efficacy. What are the results that are showing up, and how are those safety trials being developed? and then you continue to proceed to evaluate that, in those next phases, to at least where you get to the point where you feel that, okay, let's say you're 2 years out, the numbers are looking good, the data is fine, and we can then start to grow vaccine. And once you grow vaccine, that takes maybe another year or two, and then you start to disseminate vaccine out, right? That's the normal process. In a pandemic, where we have millions of people being infected, and countless dying, in the six figures and up, the scenario that fell into place was that a couple of things transpired. In December, roughly by the end of December, beginning of January, once the virus was identified, SARS-CoV-2, which we called COVID-19, that genetic makeup of that virus was disseminated to public health labs and scientific labs across the world. Canada got it. Italy got it. Everyone who had a public health lab or a scientific, laboratory, like virus, virology lab, received a copy of what that genetic makeup of this pandemic. And from that moment in time, folks either shifted work that they were already doing on vaccine development or virus development to focus on this, because it's pandemic, which means it has not existed in our lexicon for at all. The neat thing, if I can use the term neat, tongue in cheek, the neat thing about making that shift, we already had before COVID-19, we had 6 other human coronaviruses that we were exposed to. SARS-1, MERS, MERS, Middle Eastern Respiratory Syndrome, which is another coronavirus. And then there were 4 coronaviruses which were identified in the 1960s. All right. So having that, and even looking at the history of the SARS virus and the MERS virus, there were already researchers in place working on potential vaccines to address those particular viruses. So the pivot or the shift into focusing on this one was an easier framework for several, right? So it wasn't as if they started in December or January. They started focusing on the current strain that we have while using several of the technologies and the research that they've been doing for a while, sometimes 2 years, sometimes a bit more than that. So when the public doesn't really know those nuances and just hear Operation Warp Speed and there's a vaccine, they think, oh, you just created this vaccine and it's not tested. Now, in reality, as if I'm getting these numbers right, just let me make sure I say it correctly. In reality, we know that we are 43 vaccines that are currently in phase 1 across the world. Phase 1, there are 43 different vaccines that are being tested for safety and the proper dosage. Well, is this dose going to work? Is this going to be the proper one? There are 20 that are in phase 2, which means that they're expanded into safety trials in the human population and looking to really increase that group. Then there are 18 that are in the large-scale phase 3. So, there are a lot of other vaccine candidates that are out there being, tested, et cetera. And we know at least there are 6 that are in early limited use. So all that means is, because you normally follow that process that I described for like maybe about 2 years or so, what they have done, because of there being an emergency, because we're seeing a run on these deaths and these cases, the idea is like we should not wait until 2 years. We probably would decimate the entire or the human population by that time. So we will make an emergency use authorization to use what we have currently based on the information that we have been collecting thus far, which seems to be promising to some extent. So we can do that to at least save the larger humanity versus that of waiting an additional 2 years to then start to grow the virus. The other piece of that storyline is, as I mentioned to you before, you go through this process of growing the vaccine and testing it, or developing the test, and then you start to manufacture it. The difference in this case was that while the vaccine trials were being developed, there was also the decision made to start to manufacture those same vaccines while concurrently testing them out. The whole idea was, if in fact the numbers are promising, they show some, some great value in the efficacy and the data that's collected. You don't have to then sit down for another 6 to 9 to 12 months or 2 years to create new vaccine. You would have already been created and have it on tap, given if everything works out. So as a result, we now see that there's 6 vaccines that are in limited use between China, Russia, the U.S., other countries, Canada, United Arab Emirates, Bahrain, etc. 2 have been at least approved for full use, both in the U.S. and other parts of the world, such as the Moderna and the Pfizer vaccines, which are mRNA. And there's one that was actually abandoned after the trial gave negative results. I want to say negative results. It had negative outcomes, meaning because of what they did to try to secure how they wanted to detect this virus, they ended up resulting in an unintended result, whereas the body thought it was HIV and was producing antibodies against HIV, which resulted in folks getting a positive HIV result. They didn't have HIV, but based on how they had made how they had created their vaccine, the vaccine incorrectly gave the immunologic response a signal that, oh, this is HIV. So that entire vaccine trial was abandoned and basically, shelved and trashed, because you don't want to be, giving the body the perception that an individual has HIV when they don't. So with that said, when people say that, well, things are happening too fast, etc., the only thing that really happened differently was that, one, they started growing it while they were testing it out, versus waiting 2 years out to start growing it. And 2, at least the early 2 vaccines that were approved are a new style vaccine that doesn't require you to create or use a what we call inactivated virus. We don't have to use a lesser virus to enter to create a vaccine and put that in you so that you have a response. But instead, this mRNA just tells the body that to create a protein, and then that body fights off the protein with your immune response. So some of that, I would say, and having those positive results of over 94% efficacy when they probably anticipated 50 to 60, really gave that impetus for why the vaccine on an emergency basis, has been pushed out, because it shown such promising early results.
How concerned, well, yeah, I can speak for myself. When the vaccine was first announced, yeah, I started to feel a sense, with myself at least, okay, now I can relax. Don't have to worry as much about things like social distancing, wearing a mask, that we have this vaccine. You don't think about, the logistics of it. You just hear vaccine, and people are so, I think, pandemic fatigue, that this little bit of hope. How concerned are you that that might cause people to prematurely relax some of these, some of the mask wearing, the social distancing, um, because they assume that, well, now that there's a vaccine, it's the magic bullet and it'll be in everybody tomorrow or something like
Yeah, we actually advise against that because that is the furthest from the truth. One, because even the way the vaccines that are currently out right now, when the moment you get the shot, you're not immediately immune. You're not immediately, develop immunity. So you still have to create and provide those same practices that we've been doing all along: the social distancing, the wearing of the mask. With the 2 vaccines that are at least out in North America, they're 2-dose administration, which means you get 1 dose, and then 3 weeks after is you get the second dose. The data has shown that upon the second dose, you have a much stronger immune response, which is kind of saying you kind of boost the body to really improve the antiviral response, your natural antiviral responses in you. So With that said, you think about that. You take a shot, then you have 3 weeks, then you take another shot, then you have another 9 to 10 days before you really have what we would say a pronounced immunity. So the whole idea there is that just because you got the first shot doesn't mean that you're immune or partially immune. We know that because there have been people who have gotten the vaccine now and have been because they may have been incubated, et cetera, or they got it too late. They have already had. I know there are a couple of folks I saw today that they had identified as being positive for COVID, even which basically meant that they got the vaccine too late. So the scenario is really that we don't want people to have this false sense of security that everything is fine. We don't have to wear masks because there's a vaccine, because we also have a segment of the population who are not going to have the ability to be vaccinated, just because of their medical conditions or their preconditions, et cetera. So the concern there being is that you want to make sure that enough of our population, we say 70% or so, are vaccinated when the time comes, which gives us what we anticipate as a herd immunity to protect those who cannot be vaccinated from becoming ill and succumbing to this disease. So all of that basically says it's still all hands on deck, so that at least we can pay our due diligence as we try to plug through the tunnel, as we say.
Being uh, a Mason, I, as yourself, I'm always try to, be first in line or quick to get a flu shot, a flu vaccine, because many of our membership are older and being active
Hmm.
in lodge. I want to make sure that I'm not, carrying the flu on to older members of the lodge when I'm meeting. So I've myself has always been, pro vaccine, but you mentioned that number 70%, and we talked earlier about kind of this pushback to the science and this pushback to health officials. Are you concerned at all about reaching that number? Do you think a sufficient number of population will take the vaccine? And if anybody is concerned about it, I guess what would you say to them, especially any Masons who may be concerned about taking the vaccine?
Yeah, I would say when the time comes, because it's ironic. People are concerned about a vaccine, but they're nowhere close to getting it at this present moment because of the way the priority groups have been defined. So, for example, I intend on getting the vaccine the moment it becomes available, and I'm a health professional, but unfortunately, the first group are those who are in the direct patient care setting versus those So an ICU nurse may get it before the epidemiologist, like myself, would, which is fine. The concern that folks have about getting the vaccine, we've seen, of course, earlier on when the conversations were happening, that this lack of confidence, and whether or not people felt that they would or not, that number has been shifting in the last few, I would say, last few days, or at least the fact that vaccines have been rolling out. Of course, there's going to be fluctuations, whether we get more details on side effects and other elements that we may not have known or may not have seen before. But the goal of at least getting to at least 70% of the population, it's an aspiration that I believe we can get to, as long as we are able to illustrate the safety, and the science of how things are going. So right now, the folks that are being prioritized are the healthcare personnel, then the essential services, then those who have, a predisposition, pre-existing condition, or those other elements that who are greater at risk, before it gets to the general population. It is very admirable, and I always am very happy when I hear people think about others, to the sense of saying you get the flu shot because you don't want to get others sick, because especially seeing the older demographic that we have in our membership, they're at risk. They are by far, and I think sometimes they don't realize it, but they're at a greater risk of the impacts of this particular pandemic than folks realize. I can tell you there's several brothers that I've spoken to who have gotten COVID. There's several people who I know that have passed in the last year as a result of it. And of course, folks get antsy from being at home and not getting to lodge, and everyone wants to come back to just let's go back like it was before. And I would say the word of caution is advisable because we can't take risk and end up causing more harm than good, especially in our role and our moral duties as Freemasons. So, I mean, I would advise folks to definitely get the vaccine, but of course, speak to their medical professional and their doctor, personal doctor, to ensure that they have the capacity or there are no issues, no large allergies that are related to vaccine ingredients or anything to that extent. But from a general perspective, I say the sooner we are able to generate that health and safety network web of vaccinated individuals in the community, I think the better off we'll be to resustain our efforts in going back to lodge meetings and social interactions.
The other reason I would want to get a vaccine when available is because the thing I miss being from Windsor especially is the ability to travel, especially to the States.
Yeah,
Um,
yeah,
one thing, this goes to so much of a dummy I am. I never realized there was like there could be multiple types of vaccines. I just assumed there was like a vaccine shop there, and every year they made flu vaccine, and they made whatever the vaccine is you need that year. Um, I had no idea that you could have multiple types of vaccines for the same illness. One concern I had, and this is just uneducated dummy me, is with the types of vaccines, is there any concern about if Canada were to say approve one type of vaccine, but America a different, would they would they not necessarily allow travel unless everybody has the same vaccine, or is it all recognized as being the same result, even if it's from a different manufacturer or a different provider?
yeah. So I believe at least with the world stance, the several vaccine candidates that folks have had are actually global in the sense that they're not just, well, with the exception of maybe Russia, they're not only available in one area. So, as long as the vaccine that the World Health agencies do, and whether it's Canada, U.S., or otherwise, do recognize as proof of both immunization as well as freedom of safety from actually disease, I believe when we get to the chance to reopen, well, I'm say reopen because people are still flying today, but to have those ease of travels, I think that when we get out the emergency phase and get into the more regular phase, we may have that ability to really have shared understanding across the different borders as to what qualifies as a good vaccine or not. I don't believe in this particular sense. Canada is going to say, well, you have to have this vaccine versus America say you had to have that one. I think any of the vaccines, and that's why there's so many different options available, will once they meet that official capacity for approval, will qualify and be acceptable across the different countries.
As a as a right worshipful brother, so the equivalent, I'm not sure what it's called in New York. Here, right worshipful is district deputy, so responsible for a district within Freemasonry and kind of the representative of that area. Um, yeah, to me, the current opportunity or crisis or whatever it is, crisis, I guess, does present an opportunity for Masons to kind of be leaders in the community, whether it be wearing a mask, even if the mask has a Masonic symbol on it, if you want to advertise or not advertise is the right word, but promote the Masonic response to these type of things. Wearing a mask, um, getting the vaccine when available, not spreading perhaps disinformation that can be harmful. Um, and also, worrying about those social determinants of health in the sense of if somebody's lonely, giving them a call, or there's lots of charitable endeavors. There's lots of different ways that I think Masons can use this as an opportunity to show kind of what the craft can be at its best. Um, I guess what has the response been like from Freemasonry in New York through this pandemic? I know you guys were very hard hit in March. Um,
Mm-hmm.
I've had the chance to see most works with Bill Sardone on a few of those town halls.
Mm-hmm.
So I guess just how have Masons in New York and more general responded to this crisis?
So we shut down the Grand Master Sardone shut down the Grand Lodge. We normally meet in May, based on the state, guidance as far as no internal gatherings or et cetera, and everything going to the stay-at-home status. That also shut down Freemasonry. We shifted from being in-person meetings to really focusing on doing the Zoom or the electronic, media or style of interactions. And then once we got back into the reopening phase in the summer, we had actually, he'd provided dispensation for folks to kind of restart on a very social distance and reorganized format. There were adjustments made to have a COVID related, or I should say modified, ritual for opening and closing so that they would reduce any, personal interaction. And also some efforts with respect to how to initiate and bring folks into the craft while still being safe, but at the same token providing an experience that would be still rewarding to the new candidate. Now, things changed once we hit the Thanksgiving season, and things just went on the wrong direction, meaning it went up. When the government changed, New York State government changed its rules and recommended that, no gatherings for less than 10, that also impacted our lodges, especially lodges that are in regions that are, hot spots or growing areas of concern for COVID. So those several shifts, continue to this day. We're still waiting to find out what the decision will be for our next convocation in May, and how we're going to manage that. But to your question, as far as the response around the membership, it's been varied. There are members who, of course, highly concerned about their health and safety, and wanted to make sure that they, stay away from any kind of social gathering until we get full safety and full, coverage, et cetera. There are others who are antsy that, they just want to be back, giving grips and that kind of stuff and doing masonry. And there's a frustration in some regards that, some of the decision points are, not equal. So you may be in a city which has a higher density, but if I'm in a suburban or a rural community where where the virus activity isn't high, then I should still be able to attend and do lodge activities. And you make the argument either which way or the other. So I think ultimately we're dealing with the fact that we've been here before, whether it's the Spanish flu or the world wars. We've had extended period of time where there have been some shifts in the how we conducted Freemasonry. Now, the difference between that and now, we didn't have social media. We didn't have the means that we can use to at least provide some surrogates. Ultimately, I believe brothers do several folks, irrespective of in the fraternity or not, do have some fatigue, are trying to deal with the fact that we being a social group, have lost some of that sociability. But I make the argument that as Freemasons, we actually have a social contract, right? Both to ourselves, to our brothers, and to the community, to really be that beacon of light, that opportunity to show that social contract, that social responsibility in both being an avenue for folks to look to for example building, and also for generating that spirit of communalism, which is what's going to be important for us to get through this particular set of events, because whether it's due to isolation, due to mental and economic and other stress points, or even the health-related stress points, I think there's a lot of roles that Masons as a whole can play to help bring us through, especially with the significant social behavior and mental health effects that we anticipate that are going to be long-lasting due to the economic and other conditions, past the pandemic phase. So there's a level of me that really views the role of Masonry to be quite prominent and advantageous, and we just have to take the bull by the horns and just show why we are who we are, and how we can really be examples to the community and society as a whole, and in how we navigate and come out of this particular crisis.
So moving forward, um, I'm not sure what's happening in New York. In Ontario, we are going into what they're describing as a full lockdown, December 26th, for 28 days in Southern Ontario and for 14 days in Northern Ontario. I guess, yeah, moving forward, um, what are your suggestions for the best way for an individual to move forward? Is it just the guidelines that have already been set out? Wear a mask, um, social distance, pay attention to when you're eligible for a vaccine, that type of thing. I guess just
Yeah,
how are we?
I would say, given the way that we're seeing such an increased run on cases, and of course the hospitalizations, the hospitals across, the country, in both countries, I would say, are being hit to in the capacity that there's concern of how the healthcare system is going to be able to maintain such a run on, illness, and hospitalization. So if you have the capacity, to minimize your, especially around the holiday seasons, minimize the small group gatherings, the family gatherings, try to focus on, you know, what are the positive things that you can do to still be engaged with your family members and friends without running the risk of creating super spreaders or micro spreading scenarios, just so that we can get through these next month, because we're in a very tough spin as it pertains to where this disease is going. And I think the role that we each can play in ensuring that you're wearing a mask and doing proper hand hygiene, physical distancing where appropriate, try not to travel because the travel is really spiking a lot of this activity, and really, identify when it is that you will be available and can take vaccine, to do so at the moments of availability, because ultimately, if we are going to make it through this, we all have to collectively, lay a hand in that building, that break, that cement of brotherly love that we talk about, placing those foundational elements together. And I think just asking brothers to just adhere to that and do their part, I think will do wonders in getting us through several of these bumps in the road that we are going to be experiencing for the next 3 to 4 weeks.
I will, in the description to this video, um, make sure to leave the website uh, link for the National Association of County and City Health Officials. Um, any other websites that or resources or links that I should be leaving if people want to go to just to get any more information? Or let me rephrase, to get the correct information, because the dangers of social media, as we talked about, is there's a lot of information or misinformation floating around out there. So
Yeah. So I
what are
know, at least on your side of the coin, Public Health Agency of Canada or Public Health Canada, they try to provide information there. For our side, we use the CDC for data gathering efforts. There's my organization, we provide updates specifically on, what we have a data hub, and, kind of for folks to really jump in on to would handle questions that would really the public would need to probably better disseminate and digest versus the scientific piece. So there are all these elements that I would say would be very helpful to folks to avail themselves of, and at least on social media, I try to provide some some updates in a way that folks can hopefully understand, and digest, so that we at least are not listening to bad sources and repeating some of the same, illegitimate arguments that we hear from other places.
And with that, I will first remind everybody who's watching to like, subscribe, comment, all that stuff that you do to get this podcast. And right, worshipful sir, I do not in any way envy your job. I'm sure it is incredibly challenging right now, as well as your staff and the hospitals and local health agencies you're working with. Um, but it is just truly appreciated the work that you're doing to try to keep us safe and save as many lives as you can or as we can getting through the other side of this. So thank you so much for that and for all your work and for your Masonic contributions as well. Speaking at the town hall about the vaccine was, it can be a scary time. So to have somebody of your credentials speaking about this topic can be comforting for Masons and non-Masons alike. So it is much appreciated.
Thank you. It's really a pleasure. Say hi to your listeners out there. And once again, thank you so much, Brother Cameron, for inviting me to participate in this podcast with you.